Regarding the kinematics of a normal knee, from 10 degree to first 120 degree flexion, there is a lateral femoral rollback. There is interrotation of the tibia on flexion due to unequal radius of the center of rotation of the medial lateral femoral condyles. During the knee flexion, the tibio-femoral contact moves posteriorly, and that is significantly greater on the lateral aspect as the tibia interrotates to the extent that during deep flexion there is no bony contact with the lateral femoral condyle and the lateral tibial plateau. The rigid 4-bar linkage model comprising of two cruciate ligaments and the area between the bone, or as it is explained in Campbell as the relationship with the PCL and ACL with the patellar tendon and the quadricep tendon, known as a 4-bar linkage, was suggested that which causes femoral rollback. But this is a disputed concept since cruciate ligament have no isometric points and at all positions of flexion, and act as a pivot within a closed loop. So as Dr. Munawar has said, it's mostly popliteus which causes the femoral rollback. Regarding the designs, the difference between cruciate retaining and posterior stabilized total knee replacements is due to the resection of posterior cruciate ligament. There is a replacement with a cam and a post mechanism reproducing femoral rollback. Clinically, it has shown that there is no significant difference in clinical outcome or patient satisfaction following surgeries, either cruciate retaining or posterior stabilized knee. This emphasized that there should be accurate bony and soft tissue cuts to balance the flexion and extension gaps. Either of the design are effective if the posterior cruciate ligament is effective. PCL sacrificing are mostly used in case where the patient is having inflammatory arthritis, because PCL stabilization or recession is quite difficult. Retention of the posterior cruciate ligament by itself has been suggested to leads to improve proprioception, but this does not end up into superior clinical outcomes. In the posterior stabilized knee replacement, the posterior cam mechanism engages the femoral component, resulting in a constant and more physiological condyle positions in weight-bearing conditions. And posterior femoral rollback happens in a passive flexion. In cruciate retaining design, the tibio-femoral contact point tends to move interiorly instead of posterior in mid-flexion, and there is less consistent rollback in those with cruciate retaining designs.